Hi there, my valued, highly treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession. I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, I humbly urge you to sit back and spare me part of your very precious time to share some precious tips which may prove useful in your line of duty. Welcome to part 48 of our pharmacotherapy MCQ series that majors in neurology. Question number 1 reads, Mrs. KLP, a 67-year-old female with severe acute respiratory distress syndrome who is on assist-controlled ventilation, is admitted at your hospital. Your clinical team plans to initiate continuous infusion of cisatracurium. She is currently on propofol at a dose of 50 mics per kilo per minute infused IV, morphine at a dose of 2 milligrams infused hourly, pantoprazole at a dose of 40 milligrams IV once daily, heparin at a dose of 5,000 units administered subcutaneously thrice daily, and 750 milligrams of levofloxacin infused over 90 minutes once daily. Some of our vitals include a systolic blood pressure of 135, a diastolic blood pressure of 89 millimeters of mercury, a heart rate of 95, a respiratory rate of 18, and her body temperature is 101 degrees Fahrenheit. Her most recent CPOT is 2, and the RAS, that is RASS, is -2. So my question to you is, which of the options listed below would be the best combination of sedative and sedation target for Mrs. KLP? Would it be midazolam infusion with target RASS of between -1 to -2, or would it be lorazepam infusion with a target RASS of -4 to -5, or would you settle for propofol infusion with target RASS of between -1 and -2, or would you settle for dexmedetomidine infusion with a target RASS of -4 to -5? I'll give you 10 seconds to choose the correct answer. B would be the correct answer. Now we know that Mrs. KLP is going to be initiated on a neuromuscular blockade agent, what we abbreviate as NMBA, and is likely sedated based on the RASS reading. Now, once such a patient is paralyzed, it is difficult to assess pain and sedation levels. Therefore, prior to initiation of the paralytic, such patients should achieve appropriate pain control and deep levels of sedation, where deep means RASS of between -4 and -5, and the SAS should fall between -3 to -5. Now, RASS levels of -1 to -2 are the targets for light sedation, which wouldn't be appropriate in the case of Mrs. KLP. Now, the current SCCM pain, agitation, and delirium guidelines prefer the use of non-benzodiazepine agents such as propofol or dexmedetomidine in most clinical situations. However, deep sedation is required, and the use of benzodiazepines is preferred. Now, deep levels of sedation aren't achievable with dexmedetomidine, so that makes it an unsuitable choice. Now, the use of neuromuscular blockade agents requires patients to be deeply sedated. Now, deep sedation is equivalent to the Richmond Agitation Sedation Scale, what we call the RASS, of -3 to. Our next question reads, Mrs. GSK, a 36-year-old female patient, is initiated on carbamazepine by your neurology team for the treatment of trigeminal neuralgia. My question to you is, which of the agents listed below would require a dose adjustment if co-administered with carbamazepine due to a clinically relevant drug-drug interaction? Would it be pregabalin, marketed as Lyrica? Would it be Lacosamide, marketed as Vimta? Would it be perampanel, marketed as Fycompa? Or would it be gabapentin, marketed as Neurontin? I'll give you 10 seconds to choose the correct answer. So C would be the correct answer. Perampanel would be the culprit. Now, we know that perampanel, which is marketed as Fycompa, is an antiepileptic which is administered once daily orally at bedtime. Now, enzyme-inducing antiepileptic drugs cause a 50 to 75% reduction in perampanel plasma levels. Now, when initiating antiepileptic drugs such as carbamazepine to the patient's regimen, the patient should be closely monitored for clinical response and tolerability. Now, dose adjustments for perampanel may be necessary in such scenarios. Now, I'd just like to emphasize that pregabalin and gabapentin are used in the relief of both neuropathic pain and can be used as adjuncts in management of epilepsy. They are administered orally in 2 to 3 divided daily doses, and they don't have drug-drug interactions with carbamazepine at all. So that makes answers A and D wrong. And Lacosamide, which is marketed as Vimta, is an antiepileptic which is administered orally twice daily. It can also be administered via short-term IV injection. Now, that is only when oral administration isn't feasible. I would like to add that it doesn't have drug-drug interactions with carbamazepine either. So that makes B the wrong choice as well. Let's move to the next question, please. And it reads, Mrs. TOO, a 72-year-old female patient, presents to your neurology clinic. She has a past medical history of chronic heart disease status post MI 10 years ago. She's also hypertensive and suffers from Alzheimer's dementia. She also has a stage 4 chronic kidney disease, and her creatinine clearance is 22 mL per minute. She resides in a long-term care facility together with other dementia patients. They have been cohorted. Currently, she takes 10 milligrams of Lisinopril once daily orally, 10 milligrams of donazepam once a day, 10 milligrams of memantine twice daily orally, 10 milligrams of atorvastatin at bedtime, 50 milligrams of metoprolol succinate once a day, 75 milligrams of clopidogrel once a day. So my question to you is, which of her medications listed below would merit a renal dose adjustment based on her renal function? She has a creatinine clearance of 22 mL per minute. Just as a reminder. Could it be Lisinopril, memantine, donepezil, or clopidogrel? I'll give you 10 seconds to choose the correct answer. So memantine it is. Now memantine is eliminated renally for a creatinine clearance below 30 mL per minute. The recommended maximum dose of memantine is 5 mg twice a day for the immediate release tablet form and 14 milligrams for the extended release capsules. Now, donepezil doesn't have to be renally adjusted. The target dose is 10 milligrams daily unless it isn't tolerated by the patient due to side effects, which may include GI side effects and bradycardia in some cases. Now, Lisinopril alternative A may be dose adjusted based on renal function. However, Madam TOO is receiving a dose below the maximum recommended daily dose of the 40 milligram max, so I wouldn't have worries at all. Now, clopidogrel alternative D doesn't require renal dose adjustment. Now, based on the patient's expected life expectancy and presence of adverse effects, the need for clopidogrel may need to be re-evaluated. Now, just like to remind you that memantine is an NMDA antagonist, which is used in the treatment of moderate to severe Alzheimer's dementia. Now, donepezil, on the other hand, is an acetylcholinesterase inhibitor used for the treatment of mild to moderate Alzheimer's dementia. So let's move to the next slide, please. And the question reads, which of the medications listed below is considered the drug of choice in the management of absence seizures? Is it carbamazepine, phenytoin, ethosuximide, or phenobarbital? I'll give you 10 seconds to choose the correct answer. Ethosuximide it is. Now, absence seizures are also known as petit mal seizures. Now, all the three other options, that is carbamazepine, phenytoin, and phenobarbital, are known to either worsen or to have no benefit in the management of absence seizures. Now, patients with absence seizures shouldn't take phenytoin, carbamazepine, or phenobarbital because they can increase the frequency of absence seizures, just as an emphasis. Now, other treatment options that can be considered if ethosuximide and valproate derivatives aren't available include levetiracetam, lamotrigine, zonisamide, and clonazepam. However, these agents should be considered if other options can't be used. The drug reference range for ethosuximide in such patients, for your information, is 40 to 100 micrograms per ml for most patients. So just ensure your levels are within that range so that there is no toxicity and there is no breakthrough epilepsy. That's just a by the way. Let's move to the next slide, please. Our next question reads, Mrs. J.O.K., a 66-year-old female patient, presents to your hospital with intracerebral hemorrhage, what we abbreviate as ICH. Some of our vital signs include a systolic blood pressure of 100, a diastolic of 60, and that is below her desired target systolic blood pressure of approximately 140 mm of mercury. So my question to you is, which of the fluids listed below would be the most appropriate to infuse at this time in the management of JOK's case? Would it be lactated ringers, 0.9% normal saline, DNS, or albumin? I'll give you 10 seconds to choose the correct answer. B is the correct answer. According to the AHA and the American Stroke Association, hypotonic solutions and dextrose-containing solutions should be avoided in intracerebral hemorrhage, since they may worsen cerebral edema by moving from the intravascular space into the brain tissue. Dextrose, as we know, is metabolized to carbon dioxide and water. Now, if patients aren't appropriately ventilating, excessive carbon dioxide can cause cerebral vessel dilatation, and that potentially may worsen secondary ischemic injuries after ICH. Now, hypertonic IV fluids may be indicated to reduce cerebral edema. And I would just like to add that both hypoglycemia and hyperglycemia should be avoided in such patients. And intensive hyperglycemic management isn't superior to lenient glucose management. Therefore, target glucose should be less than 180 milligrams per deciliter in such patients. And if possible, any IV fluid administered should be converted to normal saline. It is safe. Let's move to the next slide, please. Our next question reads, which of the following statements is true concerning a scenario where the pain management team is attempting to switch a patient from morphine to another opioid analgesic? Is it all opioids should be converted to fentanyl equivalent doses first? Or is it the new opioid equivalent dose of oxycodone should be initially reduced by 25 to 50%? Or is it true that no adjustments in the new opioid or opioids are needed since equivalent dosing is well established? Or is it true that individual responses to opioids are fairly consistent and predictable, allowing for ease of conversion? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. Assuming methadone and fentanyl transdermal patches aren't being considered for the new opioid, the other opioids should have dose reductions of at least 25 to 50% of the initial calculated equivalent dose. That is just to err on the side of safety. Remember, doses can be titrated upwards to the response. Now, most conversions to another opioid are usually done in relation to morphine equivalent and not fentanyl equivalent, and that makes alternative A wrong. And individual responses to opioids are usually variable. They are not consistent, they They are not constant and they are not predictable. And there is usually an incomplete cross tolerance between agents, which is the reason that dose reductions are initially made to the new opioid equivalent doses. Now, assuming that methadone and fentanyl transdermal patches aren't being considered for the new opioid, the other opioids have dose reductions of at least 25 to 50% of the initial calculated equivalent dose, and that is just to err on the side of safety. I would like to remind you that in the case of morphine, 10 milligrams of the IM dose is equivalent to 30 milligrams of the oral formulation. That's just as a by the way. So let's move to the next slide. And the question reads, which of the opioid medications listed below is more dependent on the CYP3A4 enzyme system for metabolism and therefore has a greater risk for potential drug-drug interactions? Is it hydrocodone, fentanyl, morphine, or pentazocine? I'll give you 10 seconds to choose the correct answer. So fentanyl it is. Now fentanyl is a pure opioid receptor agonist. It is a major substrate of the CYP3A4 enzyme system and therefore is at a greater risk for drug-drug interactions. Just like to comment that methadone is the other opioid that is a major CYP3A4 substrate with higher risks of drug-drug interactions. Now, hydrocodone and pentazocine are more dependent on the CYP2D6 enzyme system. So that makes A and D wrong. Then morphine primarily undergoes phase 2 metabolism via glucuronidation to morphine 3 glucuronide, which is inactive as an analgesic, and morphine 6 glucuronide, which has some analgesic activity. Now, inhibiting the metabolism of fentanyl could increase its pharmacologic effect, compromising its safety in such patients. That's just by the way. That explains why B, fentanyl, is the correct choice in this particular question. Let's move to the next slide, please. And the question reads, GWB, a 77-year-old patient, suffers from periodic generalized tonic-clonic seizures. He has swallowing difficulties. So my question to you is, which of the anticonvulsants listed below wouldn't be suitable for patient GWB? Is it lacosamide, pregabalin, zonisamide, or gabapentin? I'll give you 10 seconds to choose the correct answer. Zonisamide is the correct answer. Now we know that lacosamide is an anti-epileptic drug which is typically administered orally twice daily as a tablet or as an oral solution. It can also be administered via short-term IV route when the oral route is not feasible. Now pregabalin and gabapentin relieve neuropathic pain, but they can also act as adjunct anti-epileptic agents which are administered 2 to 3 times daily in capsule or solution form. Zonisamide, on the other hand, is administered orally and it's available in capsule form. And for a patient with difficulty in swallowing, liquid formulations would be more handy, and that makes it's difficult to administer zonisamide capsules, and that's what makes alternative C the correct answer in this question. Let's move to the next slide, please. The next question reads, restless leg syndrome, abbreviated as RLS, is related to atypical dopaminergic transmission in the CNS. Now, dopaminergic agents including lopinirol, pramipexole, rotigotine, and carbidopa-levodopa reduce symptoms in moderate to severe disease. So my question to you is, in which of the clinical scenarios listed below should dopaminergic therapy be avoided? Is it in pregnancy, in a case of thrombocytopenia, in end-stage renal disease, or in hypertension? I'll give you 10 seconds to choose the correct answer. Pregnancy is the correct answer. I'd just like to emphasize that thrombocytopenia isn't a precaution for dopaminergic therapy. Dopaminergic agents listed above do not affect platelet count at all. Now, although approximately 20% of pregnant patients experience restless leg syndrome during pregnancy, there is paucity of information on dopaminergic agents use. Some guidelines recommend avoiding dopaminergic therapy during pregnancy unless absolutely necessary. They suggest non-pharmacologic interventions including low-impact exercise, avoiding dopamine-blocking antiemetics, and iron depletion if serum ferritin is low. Restless leg syndrome commonly affects patients with end-stage renal disease on dialysis. Some dopaminergic agents can be used in renal disease, for example, lopinirol, because it is mainly hepatically eliminated and not renally eliminated. Let's move to the next slide, please. The next question reads, Mr. LKJ, a 75-year-old male, is admitted to your neurology ICU following a primary intracranial hemorrhage subsequent to his apixaban therapy. During a clinical round on his third day of admission, Mr. LKJ experiences a witnessed seizure which lasts 5 minutes. So my question to you is, which of the interventions listed below would be the most appropriate for Mr. LKJ now? Would you choose to administer phenytoin at a dose of 15 milligrams per kilo via IV piggyback? Or would you administer 4 milligrams of lorazepam via IV piggyback? Or is it true that no seizure treatment is indicated because this is a primary ICH? Or would you opt to administer levetiracetam at a dose of 15 milligrams per kilo via IV piggyback? I'll give you 10 seconds to choose the correct answer. I would settle for lorazepam 4 milligrams IV via piggyback. Now, while providing seizure prophylaxis isn't indicated in patients with primary ICH as opposed to traumatic brain injury, providing supportive care and treatment of seizures is appropriate in such patients. Now, given this patient has experienced a prolonged seizure, 5 minutes to be precise, lorazepam 4 milligrams IV would be appropriate at this time. In my opinion, phenytoin and levetiracetam aren't appropriate first-line agents to treat seizures in such patients, so I would not opt for them. I would just like to remind you that status epilepticus is seizure activity which persists for 5 minutes or more. It can also be a repetitive seizure activity without a return to baseline mental status between the seizures. And parenteral lorazepam contains propylene glycol. I would just like to remind you of that. And it may accumulate, causing acidosis in patients receiving continuous infusions. So just watch out for that as you manage such patients. Let's move to the next question. The next question reads, a critical care nurse in your neurology ICU requests for a calcium channel blocker alternative from your pharmacy since her 69-year-old patient can't swallow oral Nimodipine capsules for the treatment of subarachnoid hemorrhage, what we abbreviate as SAH. The patient is currently intubated, mechanically ventilated, and has an oral gastric tube. So my question to you is, which of the agents listed below would you recommend to the nurse? Would it be Amlodipine to be administered OG? Would it be IV diltiazem? Or would you advise her to administer Nimodipine via OG? Or would you recommend IV esmolol? I'll give you 10 seconds to choose the correct answer. OG Nimodipine would be ideal in this particular case. Now, oral Nimodipine should be administered to all patients with SAH within 96 hours of the onset of the event. That is recommended by many guidelines out there. Now, even if the patient is intubated, the Nimodipine capsules can be opened, or a liquid can be extemporaneously compounded to facilitate either an OG or NG administration of Nimodipine. Now, I would like to remind you that non-dihydropyridine calcium channel blockers are not appropriate alternatives in subarachnoid hemorrhage at all. So don't opt for them. I would like to emphasize that Nimodipine has been demonstrated to improve neurological outcomes if started within 96 hours of the onset of an SAH, but not cerebral vasospasm. Now, other calcium channel blockers, notably verapamil, are used in other vascular surgeries to prevent vessel spasm when vessels have been harvested from one anatomic site other than the brain. Now, their role in cerebral vasospasm isn't very clear. Now, just like to emphasize that surgical interventions such as clipping or endovascular interventions such as coiling are surgical interventions that are commonly used in the management of patients with SAH, just as a by the way. So, my highly esteemed viewers and listeners, that brings us to the end of this video, which is part 48 of our Pharmacotherapy MCQ series. Now, if this video benefited you in any way, I would like to request you to remember to give it a thumbs up and to like it and to share it widely with your peers. And if you haven't yet done so, I would like to humbly urge you to subscribe to my YouTube channel. I would like to promise you that the best is yet to come, and I would like to thank you very much for viewing and for listening to this video. I sincerely appreciate your partnership and your continued support and kind collaboration. I look forward to interacting with you in the next video, which will be part 49 of our Pharmacotherapy MCQ series. Thank you very much for always being there for me.